and we're going to be hearing from Alex Reynolds, Director of TeleNeurocritical Care and Director of the Neurocritical Care Fellowship. Her talk today is titled, What is Neurocritical Care? And I'm really excited to hear what you've got to say about this. We all know and appreciate what the Neurocritical Care team does, but this is a rare opportunity to hear, from an expert exactly what it is, and looking forward to it.
I would just add that Dr. Reynolds is the director of the neuro ICU at the Mount Sinai Hospital and our senior neurointensivist.
Hi, thanks everyone. And Jack and Sheena, really great job. So this is a little bit of a tongue-in-cheek, what is neurocritical care? And it's really meant to sort of highlight what the role of the neurointensivist is. To give a little bit of background, which you'll see in a minute, neurointensivists don't exist at every hospital. And in fact, there are plenty of people who argue that neurointensivists don't necessarily even matter because a neurologist and a critical care doctor together make a neurointensivist. So this is a little bit of an argument against that, but also an introduction about what it is we do for the newer members of the team. So we're going to start with just a history of neurocritical care. We'll talk a little bit about data, which actually exists to support the role of the neurointensivist. And then I'll give you 3 real-life examples at the end to sort of highlight 3 ways in which I think the neurointensivist really can bring a lot of benefit to patients in the ICU. So I won't bore you too much with the history of neurocritical care, except to show you these well-known surgeons who really were the beginning of neurocritical care. And neurocritical care really started as post-operative neurosurgical units. Depending on who you speak to and where they're from, you'll hear that the first neuro ICU was really at Hopkins or Boston City. But you can see that surgeons really sort of demanded that they have these specialized places to keep their post-op patients. And I think to this day, surgeons are really the greatest supporters of the neurointensivist. Once the 1950s came about, the polio epidemic came, and this was really where we started to see the beginnings of critical care. So these were patients who were grouped together physically in the hospital. And unlike the rest of the patients who were rounded on about once weekly by a physician, these patients were seen every day by a physician. This was also the beginning of ventilation with initially use of the iron lung. And then ultimately, lots of patients were being trached early. And because ventilators did not exist yet, they were being manually bagged by medical students in shifts. Around the same time in the 60s started to be this idea of trying to diagnose what coma was. And I think part of this was because patients who were comatose historically hadn't lived very long until ventilation sort of came into existence. And so the famous Plum and Posner, which is the Bible of the neurocritical care group, they came up with this kind of book to help understand both how to examine a patient and then also how to localize coma. And shortly after that became the birth of the concept of brain death. And so, as you can see, the chair of anesthesiology saying, with the advent of ventilation, people were being rescued, and sometimes all that was rescued was what they called a decerebrated individual. And so this was called the hopelessly unconscious patient. And there was sort of a move to talk about what to do next once we had resuscitated patients. But unfortunately, there had been catastrophic brain damage. By the early 70s, there were CAT scanners. And so people could actually look without a pneumocephalogram to see what the parenchyma of the brain looked like. And by the 80s, neurologists were starting to round on complex neurosurgical patients and neurological patients. And, some of the first neurologists to round on these patients, they were really rounding in generalized or mixed ICUs. And so this concept of the neurosurgical intensive care unit sort of came about in the early 80s. And the idea was that these were patients who had intracranial pressure issues, who were being ventilated, patients with severe neuromuscular respiratory failure. And these were patients where a neurologist could help what was generally an anesthesiologist running the general ICU. And then Dr. Betterson can probably talk about this better than I can, but ultimately the Neurocritical Care Society was founded. Annual meetings began in 2002, and the UCNS fellowship accreditation began in 2008. And not to sort of say how old I am, but I was in high school when Neurocritical Care Society was developed, and I had graduated college before fellowships were actually accredited. So this is really quite a young specialty. And I think when you see all the data that's been developed and generated in order to defend the specialty, it's really because this is still quite a young specialty that a lot of people don't sort of understand. And as you guys know, I think the ACGME fellowship accreditation began in 2022, so just 2 years ago. And so that sort of brings us to what is the data behind whether a neurointensivist really matters or not. And when we start with the data, the question is, what is the neurocritical care patient? And so I think most people would agree that ICH and subarachnoid hemorrhage is a patient who belongs in the neuro ICU. Isolated traumatic brain injury does. Mixed brain injury oftentimes is not in the neuro ICU. But then we sort of get into, I think, areas where one might argue that this is a generalized ICU patient that just happens to have some neurological issue. And so primary status epilepticus sure can be a neuro ICU problem, but we see patients who have status because they're in the ICU for some other thing. And then certainly as you go down and it becomes more and more vague, undifferentiated coma is something that in most hospitals would be seen by a general neurologist in an ICU as a consult, whereas at Mount Sinai, we really do that as a neurocritical care consult. But I think it's sort of worth thinking about what patient population we really think belongs in a neuro ICU. And I think if you're a neurointensivist, you sort of want all of those patients to be in your ICU, but that's just not really practical. And so if we go back to 2013, this was a paper published in Neurocritical Care showing the benefit of a neurocritical care consult service on patients who had ICH. And you can see before versus after, you saw a benefit to patients in that basically the very classic guidelines were being followed all of a sudden. So systolic blood pressure had been better controlled and dysphagia screens were being done. And this was really just with a neurocritical care service rounding once a day in a mixed ICU on ICH patients. There was a little bit of a worsening in ICU length of stay. And so a lot of people said like, well, you know, these are patients who don't necessarily need to be in the ICU, but these neurointensivists are sort of sitting around and telling us that they need to be watched a little bit more closely. And what you don't see here is bounce backs to the ICU, which I suspect were probably higher before the consult service came on. Later on in Albany, this was a paper published in Critical Care Medicine looking at the neurointensivist-led ICU service. So again, this is a semi-closed neuro ICU where a neurointensivist really led the service and then other services were sort of contributing. And you can see that here ICU length of stay actually dropped after the neurointensivist joined. And the number of patients who are being either discharged home or sort of to a skilled nursing facility actually went up. And you can see that the cumulative incidence of death sort of dropped and the incidence of discharge slightly went up. This was a paper done in New York showing just the prevalence of neurological patients in ICUs at in a 24-hour period. And so it basically was just a slice of New York City ICUs. And so they looked at the differences between neurologic patients who were admitted to a neuro ICU versus a general ICU, One obviously can argue that the centers that have a neuro ICU maybe have more resources, although that's not necessarily true across the board. But you can see that these were patients who ultimately in a neuro ICU were receiving more invasive intracranial and hemodynamic monitoring. They had earlier and higher rates of tracheostomy. They had more nutritional support and earlier on and less IV sedation altogether. And I think that sort of makes sense when we think about the neuro patient in another ICU who doesn't necessarily get their sedation holds and their neuro checks as frequently. And so these were patients who had diagnoses of ischemic or hemorrhagic stroke or TBI. And you can see very significant differences between the two groups. Now, globally, they've tried to look also at whether places that have a dedicated neuro ICU benefit in any way. And I think, again, this is sort of a resources issue. And so in poorer countries, you won't see as many neuro ICUs, but also in Europe, there are not as many neuro ICUs as there are in the US. And so having a dedicated neuro ICU across the board was an independent predictor of lower inpatient mortality. But despite all of this, there were some questions. And so recently there was a systematic review and meta-analysis of all the data published in JAMA Neurology. Now, the limitation here is that it's a meta-analysis of all patients and all units who had some sort of involvement of neurocritical care, but that could have been as a consult, that could have been in an open unit or a closed unit. And so the effect is probably diluted out, but there was seen over the course of all of these different papers, a 17% relative risk in mortality and in unfavorable functional outcome. I think a lot of times people argue that a decrease in mortality means an increase in unfavorable functional outcome in the neuro ICU, but that wasn't the case here. Despite this, there's a lot of debate, and I put this up to show that in 2021, I was invited to the Society of Critical Care Medicine to argue against the use of neurointensivists for neurocritically ill patients. And so this is still a topic of debate, and I think that it's probably not just going to be data that changes people's minds, but kind of primary interaction with patients in a neuro ICU and with neurointensivists to really change the culture in a lot of the US. I also want to point out that it's not necessarily just the neurointensivist that contributes to all of this, but that the backbone of neurocritical care is really multidisciplinary care. And so the effect of nursing and specific speech and PTOT, early nutrition for these patients. I think this is all really important in seeing the benefit, particularly I would say the neuro checks. And I think that, patients in other ICUs, they just aren't checked on as frequently neurologically, and they just tend to be more sedated. And so things are missed. So I thought I would just show you 3 real life examples to make the points that I think are sort of the main benefits of the neurointensivist. And so we'll sort of go case by case. So I think recognition of neurologic emergencies, both by the nurse and the neurointensivist, is really a benefit. And I'll show you this case that many of us know. A patient in his 60s with no past medical history had presented for this large CP angle mass. He had a long surgery. The cerebellum seemed to be swollen intraoperatively. And on arrival to the neuro ICU, he had a wake-up exam, and he was looking around very uncomfortable and desynchronous with the ventilator. And he was following everything. He was like intermittently following commands, but moving everything and very strongly. And this is his imaging here. And I got called in around 9 or 10 p.m. because the patient was suddenly going in and out of non-sustained VTAC. And actually the in-house intensivist had come to help manage the patient while I was on my way in. And ultimately he was controlled with amiodarone and lidocaine boluses and drips to control the VT. And the medical intensivist was like, don't worry, like the VT is now under control. You don't need to come in. Everything's fine. But I insisted on coming in because the patient didn't have a cardiac history. And so from the intensivist standpoint, a general intensivist standpoint, these are the reasons for ventricular tachycardia. And so an EKG had been done, didn't look like he was having ischemia. Bedside echo looked good. Electrolyte abnormalities were really not present. And so it was sort of, well, we fixed it, but we'll look into these things. What the neurointensivist knows is that bilateral brainstem compression can also cause VT. And so when I arrived on exam, he had ocular bobbing. He was posturing in all four. We bolused him some sedation. We gave 23%. And actually, even with sedation, after the 23%, he became semi-purposeful, was starting to localize with his arms to the ET tube. And he had a repeat head CT, which showed that there was worsening swelling of the left cerebellum. And so this was really like right after the VT event at the bottom. And so what happened was actually the patient had an EVD and the intensivist said the ICP is normal. But we knew that compartmentalized ICP is not going to be transduced on an EVD. And so he went category 1 to the OR. The left cerebellum was very swollen, was partially resected. And by the next day, he was attending following commands and was extubated and discharged to rehab. And so I think this is an example of where the general intensivist might not recognize that certain symptoms are symptoms of herniation. And were this patient to be in a unit that was not a neurological unit, things like posturing or ocular bobbing and VT may not have been identified as being signs of elevated ICP in a compartmentalized way. The second case is sort of optimizing the treatment of the brain. And I tell this to our fellows all the time when I say that you really need to know your general critical care better than the general intensivist, because we need to be able to optimize our general treatment in order to protect the brain. And so this was a woman in her 60s with chronic thrombocytopenia, and she had presented with a high-grade subarachnoid hemorrhage. She was transferred to us. And her course was complicated by refractory ICP, and ultimately she required bilateral EVD placement over several days. And her exam improved on post-bleed day 2 to opening eyes, following in all 4 extremities, and she was actually extubated. Post-bleed day 5, she developed symptomatic vasospasm, but she also developed a GI bleed. She was newly going into DIC, with evidence of new coagulopathy. And despite transfusion, her hemoglobin continued to drop and she was requiring escalating pressors. And so we reintubated her and we convinced GI to come and scope her. And when GI came and scoped, they found a huge amount of blood throughout the stomach and duodenum and a vascular lesion in the fundus of the stomach, which they attempted to clip. And when they did attempt to clip it, this on the left happened. And this is everybody's nightmare. This is not a sped up video. This is just massive hemorrhaging out of the GI tract. So she, within 10 minutes, she had 4-liter blood loss. We activated massive transfusion protocol. She was getting code doses of pressors in order to prevent her from coding. And after her second round of MTP, she developed elevated peak pressures. We were unable to ventilate her. She had massive abdominal distension. We were ultimately paralyzing her for vent synchrony and noted that she had abdominal compartment syndrome. This is her chest X-ray on the right. And so if you kind of take a look at her current issues, she had started with poor intracranial compliance and cerebral vasospasm, and now over the course of an hour has developed ARDS type lung physiology, abdominal compartment syndrome with oliguric renal failure, acidosis, total volume overload, and a massive GI bleed. And so if you take a look at the medical management for these things, in order to perfuse the kidneys and the heart, we aim for a MAP of greater than 65. We allow for permissive hypercapnia and high PEEP in order to treat the ARDS. This patient would have been aggressively diuresed. Hemodialysis probably would have been started. Sedation and paralysis for vent synchrony, and a hemoglobin goal would have been 7. However, if you look at the neurologic management of these things, a lot of these things are just not adequate in order to protect the brain. And so a MAP of greater than 65 is probably not appropriate for cerebral perfusion. Permissive hypercapnia and high PEEP will increase her ICP. Aggressive diuresis, if it's too aggressive, might actually worsen her vasospasm. Hemodialysis may make her ICPs worse, depending on how you initiate it. And while heavy sedation and paralysis are great for her ICP, they also make it very hard to monitor her vasospasm. And there is some data suggesting that a hemoglobin goal of up to 9 or even 10 is better for patients who have vasospasm. And so you can sort of see here how the things that would have been done by a general intensivist would not have been putting the brain first. And so ultimately, I think this is an example of where a general neurologist or even a stroke neurologist and an intensivist may not be able to understand the general physiology enough to be able to prioritize the neurologic management in a very, very sick patient. And then I think the third case is avoiding therapeutic nihilism. And I think as people, we all are in the neurosciences, and I think we all recognize that people outside of neuro both have neurophobia and also don't understand neuro. And there's a lot of sort of thought that like, ooh, this patient looks bad, like it's the end. And that really comes from therapeutic nihilism. And I think an important thing as a neurointensivist is to recognize when there is a salvageable patient and really try your best to sort of protect that patient from the general intensivist in some ways. And this is not to say that, you know, we necessarily are always right, but I do think when we do consults in other ICUs, we have to sort of push back against this concept that the patient has had a neurologic injury and therefore it's the end. And so I present to you a 29-year-old woman who was brought to an outside hospital with new onset refractory status. She had no past medical history. She was transferred to the NSICU, where she had an extensive workup that was all negative, as is very common with patients who have NORS or new onset refractory status. She ultimately had her CSF sent to the CDC to see if they could test for anything. She had a brain biopsy that unfortunately did not show much except encephalomalacia. And so in her treatment, she received medications targeted towards, anti-inflammatory things in case this was either a para-infectious process or an autoimmune process. So she had steroids, plasma exchange, IVIG, and anakinra. These were all the anti-seizure meds that she was put on. So 10 anti-seizure meds. She was on anesthetic drips for 4 weeks. She was actually maxed on Versed and ketamine at some point. And so we just switched her to pentobarbital because she kept seizing through Versed and ketamine. We had a VNS placed thanks to our surgical colleagues. These were her hospital and medical complications, and obviously they're too long to really go through, except to recognize that a lot of these things are either the sequelae of being critically ill, like pneumonias and bacteremias and things, or they're the sequelae of the treatments that we are providing. So things like agranulocytosis, drug-induced metabolic acidosis, and transaminitis. These are patients who, if they don't die of their seizures, they die of what we use to treat their seizures. And so we really have to be careful when we're taking care of these patients, not to harm them while we're trying to treat their seizures. And so, we had CCM fellows rotate in and out, and they sort of, they asked, what are we doing here? Like, this has been months of this poor woman sitting here. Like, is she ever really going to get better? And in fact, at some point, her mom even asked, like, are we just like overdoing it? Like, do we just need to make her comfortable? This was Neha and me visiting her in rehab. So she was comatose for 70 days, ventilator dependent for 83 days. She went briefly to our acute rehab before being discharged to Australia, where she was from. And it took her about 15 minutes to open her eyes enough to take this photo with us. And 4 months after discharge, she celebrated her 30th birthday with her mom. And 5 years after discharge, we tried to recreate the picture of her with me and Neha. And she's returned to her job as an architect. She's extremely high functioning. she's on a couple of anti-seizure medications, and her VNS has been working so hard that she's needed the battery replaced already once and is close to needing it replaced a second time. But she traveled to New York by herself recently and stayed here for a month on her own. She's trying to convince her mom to let her move back to New York by herself, but obviously her mom is traumatized. And so this is a situation where, you know, even her mom was like, this kind of feels like the end. Like, what are we doing? And I think in another ICU, she probably would not have survived. And so that's just my third example of how the neurointensivist might be helpful. And so with that, I want to stop here and answer any questions. And thanks for your attention.
Awesome presentation. Any comments or questions?
Yeah, JB, it's Saturday. Can I just say thanks, Alex? Great talk and great overview. Germaine, to your point about epilepsy, of course, this is a big team effort between all of us. And thank you for keeping an open mind about surgery. I talk about VNS nowadays as an analog to the decompressive hemicraniectomy in simplifying a patient's care. You alluded to the fact that the medications and the treatments that we're putting patients through can sometimes be life-threatening themselves. VNS is a very uninvasive surgical option that can help in many of these cases, not all of them, but I'm so glad you're thinking about it as an early line therapy to simplify ICU care.
Well, and I think that one of the benefits of being in a neuro ICU is that you have such a close collaboration with stroke, epilepsy, neurosurgery. And I think that benefits patients, because if this patient was in a medical ICU, I don't know that the general neurologist would have thought about VNS, right? So I think we're very lucky to work in such a collaborative space.
Well, the lucky ones are us. And I think you may be preaching to the choir a little bit in conveying how important neurocritical care is. There are many nuances to this. When I came in '92 to Mount Sinai, there was no vascular program, no neurocritical care. As Alex implied, I was a founding member actually of the Neurocritical Care Society. I was just looking at my computer as you were talking to my files from 1992, 93, and then all the way through to a full decade before the real formation of the Neurocritical Care Society. In those days, neurocritical care was focused almost entirely in vascular and trauma. And the concept of an isolated ICU was really a bizarre concept. I do think that there are different types of neurosurgery relative and that will benefit differentially from neurocritical care. In the same way that we sometimes will treat the brain differently than the heart, we will definitely treat cytotoxic and traumatic and vascular brain injury differently than we treat vasogenic edema related to a brain tumor. And sometimes those two can conflict with each other. We tend to load patients in a neuro ICU and sometimes actually drying them out, and a gentle touch is needed in brain tumors. So we'll see how that differentiates. One of the most impressive things that we have here is a large team. And I bet you that not everyone knows who we even have on the team here, but we have Neha Dengaj, Cappy Lei, got John Liang, Alex Reynolds, Heyyoung Biang, Dana Klavansky, Fernando Carvalho, Gabriella Keaton is starting up, Greg Kapinos over at Elmhurst. So we have a major team, big division, and I think an outstanding one. So hopefully the division continues to grow. We continue to refine. The research continues to grow. It's an awesome division, and I hope that we see it just blossoming over the time in the future. Thank you very much for the presentation.
Thanks.
Thanks, Alex. The one other comment that I wanted to make is that with the struggles that you've described in adult neurocritical care sort of mirror, or what happened 20 years ago in adult neurocritical care, sort of mirroring what we're going through now. In that some pediatric intensivists are finally starting to subspecialize in neurocritical care, and I think that's starting to improve pediatric neurocritical care. But a little bit behind. It's a smaller specialty.
Another thing that we're going to be dealing with in the next 5 to 10 years is the expansion of our service line across a bigger geographical area. So, for example, at Morningside, we are going to be doing more and more neurointensive care as the vascular service grows there, with recruitment of new people, the beginning of biplane angiography treatments, and so on. And so there's going to be a period of time where we have neurointensivists and neurointensive care, but we don't necessarily have an isolated unit. And that poses particular challenges. But we'll have to, we'll have to kind of figure that out as we go.